It's now time to call upon our next keynote speaker. He is going to help us dive deeper into the oh-so-relatable relation of caregiving and aging. Please welcome Dr. Aaron Blight.
So I'm going to give everybody an opportunity to stand if you want, because I know I get really fidgety just sitting all day in a meeting. So please stand up and just sort of wiggle, head, shoulders, knees, and toes. If you want to do that, that's cool. I'm totally good with that. Please stand, please, please. So Amish was talking a little bit about the 15-minute increments that physicians have with patients. 4 times a year, he'd use the example of the 70-year-old who sees their doctor 4 times a year in 15-minute increments. Is that enough? How much does the doctor really understand about what's going on with that patient? And he said, not a lot. We're going to talk for a few minutes about the people who really understand what's going on with that patient, the caregivers. The caregivers are often invisible in the healthcare delivery system, but they're also indispensable. So to start off, I have a question. Does anybody out here know Morse Code? Anybody know Morse Code? Nobody? All right, I don't understand it either. For me, Morse Code is like gibberish. It's like tap, 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 tap. I don't get it. I hear it, but it just doesn't make any sense to me. Well, it was like that when my mother-in-law was diagnosed with cancer. She had a brain tumor, unexpectedly. She was 59 years old. I was 29. And we had no idea what her cancer was going to mean for our lives. It changed the trajectory of my life. At the time, I was working at this agency. It used to be called the Healthcare Financing Administration. That's where I was at the time. Changed to CMS. I was a Medicaid guy. I worked in the Disabled and Elderly Health Programs group. I was writing national health care policy for elderly and disabled people. But you know what? I didn't have a clue what it meant to be elderly or disabled until my mother-in-law got cancer. She had 6 to 9 months to live, is what they told her. All that we knew is that my mother-in-law needed help. We were her family, so we invited her into our home for 2 weeks to recover from brain surgery. She stayed in our home for almost 2 years. She went through 2 brain surgeries, radiation, chemotherapy while she was in our home. My wife got pregnant with our 4th child. We had kids all 8 and under at this time. Things were crazy at this time of our lives. And I was in the sort of like the building phase of my life, right? I wasn't supposed to be taking care of my mother-in-law at this point, but here she was in our home. We're managing her and we're managing our children all at the same time. She lived for 5.5 years. She was a miracle. Johns Hopkins University wrote a case study about her because she survived this brain surgery and they were learning from her. The problem is she was in a constant state of cognitive decline over that 5.5-year period. In one of the follow-ups with the doctor, they told my wife, well, your mother, I'm sorry to say, is going to become a vegetable and there's nothing we can do. We don't know what to do anymore for her brain. It's going to be gone. Thankfully, cancer took her, and she was still somewhat her former self when she died. A year after she passed away, I opened a home care company to help families just like mine who were dealing with caregiving challenges. This is the company that I was associated with. I was a franchisee for Home Instead Senior Care, had a couple of different franchises, and I got to help thousands of families who were dealing with these similar types of challenges. Then I got this crazy idea to go back to school and get a doctorate degree. And I had a challenge in my business of turnover with caregivers, and I wanted to try to figure out how to address that. So I studied caregiving as a phenomenon of social science. I got into the family caregiving literature, the nursing literature, the direct care aid literature, nursing home literature. And this slide represents the years of my life that I spent studying caregiving. So about a year and a half ago, a gentleman came and offered to buy my company out of the blue. He lived in Texas. I was in Virginia. It's one thing to have in your mind, and I know we got some entrepreneurs here. It's one thing to know in your mind what your business is worth, right? Okay, you have some. That's just like a number in your mind. It's something totally different when somebody brings you a piece of paper and says, "Here, I will pay you this to buy your business." And I was like, "Oh my gosh, I have to seriously think about that." So my wife was just like, "Yep, you got to do it right now. Got to sell." I wasn't so sure because I didn't know what to do. But I did it. I sold my business. My life was changed forever. But then it was like, well, what do I do? And I realized between family caregiving, healthcare policy and Medicaid, being a home care provider, and also studying caregiving and all of the academic stuff, I said, I got to go out there, and I can't just put that knowledge on the shelf. I have to come and share some of these things with others. That's why I'm here today, because I want to talk to you about caregiving. You see, caregiving is everywhere, but we don't really think about it. I'd like to just take a moment and invite you and ask you this question. If your life was touched by caregiving, will you please stand up? Wow, just take a look around the room for a minute. These are people whose lives were touched by caregiving. I'd like to take a moment and honor you and thank you for your service for those that you cared for. Now, one more question for those who are standing. If your life was changed by caregiving, please remain standing. Wow. Okay. Thank you. I've done this a few times in different audiences. A couple observations. Number one, it's amazing how many people stand up and then how few sit down. Once you get involved in caregiving, it changes your life. But you don't really understand it. You don't know what to do. I have a friend who's an anesthesiologist. He was on a skiing trip with his 10-year-old daughter, and she slammed into a sign. She was laying on the ground in tears on the mountain, and he skied up. His other child told him, "Oh, she's on the ground. She hit the sign." He skied right up to her, and immediately dad mode kicked in. He got down on his knees and he started moving her around. He's like, "Sweetie, are you okay? Are you okay? What? I don't know what to do. I don't know what to do." He's an anesthesiologist, for Pete's sake. I met him. He called me and asked me to come to the hospital to talk to him. So in the hospital, he's telling me about what happened on the mountain. And through his tears, he's telling me, I'm an anesthesiologist. I should have known not to move her. Why was I moving her? I would have never done that with a patient. It's because dad mode kicks in. So let's talk for a minute about, there we go. A couple of things about caregivers being indispensable. This slide demonstrates the estimated economic impact of unpaid family caregiving. So family caregivers get involved with their loved ones. This is 2013 data. At the time, $450 billion was estimated to be the economic value of unpaid family caregiving. Now, the other bars on this pyramid represent long-term care spending. So the economic value of unpaid family caregiving exceeds all of the economic impact of the long-term care industry. All of the other payers in long-term care are smaller than the economic value of unpaid family caregiving. The United Nations came out with this stunning statistic this year in 2019. For the first time in human history, there will be more people over the age of 65 than under the age of 5. That's astonishing. Never in the history of the world has the population been so upside down? And you can see the projection over the next 60, 70 years, more and more people over age 65 than under the age of 5. That's a lot of people who are going to need care and caregiving. So this is important stuff. But when I was taking care of my mother-in-law, I didn't understand it at all, even though I was writing disability and elderly health care policy. I didn't know the caregiving code. So I'm going to share with you 4 elements to the caregiving code today, and I hope that you remember them. The 4 elements, each one starts with the letter R. There's an R for each part of the caregiving code. The first part is roles. Okay? Caregiving inherently involves 2 roles, caregiver and care receiver, right? So if this was a play, the lead actor is the care receiver. The care receiver is the first one to step out on the stage. The script is written by the changing health conditions of the care receiver. The caregiver is the supporting actor. The caregiver follows the same script as the care receiver, but the caregiver has a secondary role. The stage is the home or the facility where the care is being provided. Now, here's the thing about this particular play. Neither care receiver or caregiver auditioned for the role. The role was thrust upon them because of the health conditions of the care receiver. Nobody wants to be a care receiver. But yet, here they are, the star of the show. Second part of caregiving, the caregiving code, is relationships. Caregiving changes relationships. Every human relationship is unique. I'd like you to think for a minute about someone in your life who's special and close to you, who's cared for you. Maybe let's use the example of your mother. Maybe your mother's not involved in your life. Think of someone else, an uncle, your spouse, whoever. But I'm going to use the example of your mother. Okay? Your mother is very unique in your life, right? There's nobody like her. The way that she talks to you is unique. The things that your mother says to you are unique. The things that you think about your mother, unique. The things that you say to your mother are special because that's your mom, right? Well, when the mother who cared for you now requires care from you, things are going to be different. The things that you say to your mother will be different. The things that you think about your mother will be different. The things that your mother says to you will be different. The things that your mother thinks about you will be different. All of these things change because of caregiving. So, when my mother-in-law moved into our home, by the way, I loved my mother-in-law. She was fantastic. She treated me like a son from the moment that I met her. But when she was in our home, I came up with this term that I started using. The nuclear family. Me and my children and my wife, right? Because we were the stars of the show, right? Not my mother-in-law. She wasn't included in the nuclear family. I would go to work, long day at CMS, and come home, and I'd sit down at the dinner table, and right in front of me is my mother-in-law. Every single day. I'm kind of ashamed to tell you this, but I got to the point that I could not look at her. I would just sit at the dinner table and just eat my dinner. And I wouldn't look up because she's there. I just look down and say nothing. That was my dinner. You see, I hated the fact that she was there, but I wanted her to be there. I knew that she needed our help, so I wanted to help her, but I didn't want her to be there. Things were changing in our family. 15 years later, I learned family caregiver identity theory from 2 applied gerontologists, Rhonda Montgomery and Carl Kozlowski. Brilliant stuff. I'm going to introduce it to you in this slide. Family caregiver identity theory describes family caregiving as a series of role-based transitions that are rooted in the changing healthcare conditions of their loved one. This is an example of a spouse. Okay, let's say it's a wife. The wife, and the pie chart represents the relationship, the tasks and the interactions that are involved in the relationship of a wife and a husband. So the wife has always been a wife to her husband, right? Well, now that her husband starts to have some health issues, the wife starts to maybe do a little bit of caregiving. She doesn't even think about it at the time, and that's phase one, where caregiving starts to enter into the relationship. Eventually, over time, caregiving starts to overtake the relationship. As you persist in caregiving, you become more a caregiver and less a wife. This is extremely difficult for people. It affects with you, it has psychosocial relational implications for you. Your whole relationship with that person changes. That's why family caregiving is so hard. Thank you. Halfway, that was the halfway sign. That's why I had such a hard time with my mother-in-law in our home. When I learned this stuff, as going through my doctoral degree, when I would meet with families, I would break out a piece of paper and I'd write the pie charts and I'd talk about family caregiver identity theory, and they would be like, oh my gosh, that's me, that's my life. No wonder this is so difficult. I took Ron Montgomery and Kozlowski's model and I applied it to paid caregiving. Instead of spouse and caregiver, here we use the term companion and personal care aide. Paid caregivers go through the same evolutionary dynamic process in caregiving, because again, it's all about the script, right? The script is the evolving, changing needs of the care receiver, and the caregiver has to adapt in that supporting role. I had the chance to present this, by the way, in a conference when Rhonda Montgomery and Carl Kozlowski, they were sitting right there in front of me in this table. You ever watch like American Idol or The Voice, and you got like the contestant on the stage singing the song that the judge sings? That's what it felt like. They were sitting right there looking at me the whole time. Afterwards, they come up to me and they're like, hey, can we talk to you outside in the hallway for a second? Like, okay, yeah. So went outside of the hallway, and Carl Kozlowski, who had Parkinson's at the time, very slow, laborious speech, he said to me, you took our family caregiver identity theory and applied it to paid caregivers. Pause. I'm like, yeah? I'm just waiting for him to just hammer me, right? He goes, that was brilliant. And Rhonda said, yeah, we would have never thought of that. Wow. So that led to a 2-hour conversation, and Rhonda Montgomery asked me to join her company. So I had the chance to work with her, studying family caregivers and trying to commoditize family caregiver identity theory through a protocol that supports family caregivers. I'll talk to you more about that later. If you want to talk to me about it, let me know afterwards. Point number 3 of the caregiving code is realities. Let's be honest about the realities of caregiving. Caregiving is not sexy. Think of some sexy roles, right? Scientist, sexy role. Leader, sexy role, right? Actress, very sexy. This is not a Las Vegas show, folks. This is real life that we're talking about. These are real people, real conditions, and it ain't sexy. Who wants to be a caregiver? Even worse, care receiver. Who wants to be dependent upon other people for activities of daily living? This is real life. Caregiving is hard. Physically, it is hard. Caregivers are engaged in all kinds of physical tasks, lifting their loved ones, running back and forth to the doctor, making meals, doing all these different things. But emotionally, it's even harder. Did you know that caregivers suffer quadruple the rates of clinical depression compared to the average population? I'm going to come back to this slide here in a second. Another reality, caregiving doesn't pay. I know a woman that I was just talking to a couple weeks ago. She is in a position where she has to decide between her job and her father. Nobody should have to make that decision. But that's where she is because of her father's needs right now. Even among paid caregivers, we don't pay them very well. $10, $11, $12 an hour, okay? We've devalued this role in our society because they're invisible, but yet they're indispensable. Sorry, the slide's out of order. Last reality about caregiving that I want to mention. Caregiving forces you to confront marginalizing assumptions about the human body. So our society, our culture says, oh, yeah, we're supposed to look like that, right? How many of us look like that? Most of us don't look like that, right? Most of our bodies don't really work like that either, right? Well, the body fails when you get older, folks. First thing that you see is maybe like the eyes, right? The eyes start to fail. So what do? You go and you get glasses, and you talk about how your eyes fail. Your ears might fail. You go and you get a hearing aid, right? Your hip fails. You get a hip replacement. Your heart fails. Triple bypass, right? Fix that heart. Well, there are two parts of the body that also fail that we don't talk about. The bladder and the bowel. Yeah, they fail too. I'd like to tell you for a minute about one of my very favorite clients, Mr. Henderson. I love this man. He was a university professor, brilliant PhD. I could sit and listen to him talk for hours. I was getting my own doctoral degree at the time that we had him. He's 88 years old. I came into his home one day, and Mr. Henderson was blind. He had gone blind in his old age. He spent his whole life seeing. So I got to his home one day, went to his back room where he was laying on his bed, and as soon as I walked in, he heard me, and he stood up, or got up on his bed like this and kind of looked over in my direction without looking at me. And I said, "Hi, Mr. Henderson, how you doing?" He goes, "I'm incontinent." That was it. I was like, oh, gee, Mr. Henderson, it happens, it's all right, no big deal. But I learned something from Mr. Henderson that day. Here is a man who had spent his entire life studying and reading, and he was more concerned about his bladder than his blindness. It shouldn't be that way. But his incontinence made him feel less than human. Did you know that up to 75% of nursing home residents have some degree of incontinence? But we can't talk about that, right? We don't talk about incontinence for adults. But it's the reality of life. So, last part of the caregiving code is rewards. Even amid all of the burden and the stress and the realities and the challenges of caregiving, family caregivers report altruistic benefits associated with care. They learn from the care receiver. If you're taking care of a dying person, you learn a lot about life. Watching someone closely as they face the physical, emotional, social, and spiritual realities of death, it's kind of a sacred experience. Family caregivers report that they get satisfaction knowing that their loved one is receiving the best possible care because they're the ones providing it. Family caregivers report a greater meaning and purpose in life as a result of their care experiences. And also, caregiving teaches us how to give more love, and thus how to receive more love. It teaches us to be compassionate, kind, empathic, to be better human beings. So as I prepared for this talk today, this is kind of the caregiving code: roles, relationships, realities, and rewards. If you contextualize caregiving and you think about caregiving in these four domains, understanding the roles, honoring the relationships, confronting the realities, and cultivating the rewards, that really establishes a great framework for action for working with caregivers. And as I thought about our audience today in IFAH, I have 5 tips that I just want to share with you as I close. 5 thoughts about caregiving that hopefully can help you in your business, in your practice, as you are helping patients, as you're thinking about what can be done to advance healthcare in the future. Tip number 1, caregivers can be a resource for understanding and serving patients. Caregivers are marginalized in the healthcare delivery system because in the healthcare delivery system, it's all about the patient, right? It's all about the patient's conditions. It's all about all the billing, all the treatment, everything is focused on the patient. They're the star of the show, right? But the person who knows the patient best, the person who is with them for hours on end, is the caregiver. The caregiver often observes behavioral changes and is able to detect, oh my gosh, we just introduced that medication. It must be that's triggering this weird behavior that I'm seeing today. Tip number 2. Caregivers comprise a big underserved market that can be tapped. This is kind of an adjacent part of healthcare, but there are 44 million caregivers today in the United States alone, and they have needs. They ignore those needs because why should I be worried about myself when it's so obvious what my loved one needs? Tip number 3. Caregivers are often the decision makers for care receivers, especially the elderly. So often the caregivers are the ones that are making the decisions when it comes to long-term care, placement in nursing homes, decisions about what course of treatment to pursue. Caregivers are very influential in those decisions. Tip number 4. Recruitment and retention of paid caregivers is a huge issue. If you are interested in this issue, please talk to me. I would love to pick your brain a little bit and talk to you about this. But if you have a tool that you can develop to help figure out how to hire and keep the best caregivers, that will be gold. Last tip. If you make life better for a caregiver, then you're also making life better for a care receiver. It's important to remember that because of the symbiotic relationship between the two. So I'd like to hear what you think about this. This is all my Twitter handle and all that stuff. That's my cell phone. That's my cell phone. I have it right here. So let me know what you think. I'd love to talk further with you about caregiving and caregivers. Thank you very much. Questions? Okay, time for questions. All right. Yeah.
Are there HIPAA concerns bringing in the caregiver to the doctor's visit?
The question is, are there HIPAA concerns bringing the caregiver into the doctor's visit? That's really the decision for the patient to make, right? So the patient has control over disclosure of their healthcare information. So if they authorize that, it's fine.
Good morning. When you had your home care company, what tools did you use to retain caregivers?
I established reward programs for caregivers. And the reward programs were revolved around some of these ideas. I had a lot of, and it's important that caregivers are recognized. And you can come up with rewards that don't cost a lot of money, that are highly effective because they tug at your heart. Because caregivers they work from the heart, okay? The best caregivers are motivated by the heart. And so if you are able to construct reward programs that recognize their service and their devotion to their clients and honor the relationships that they have with their clients on a very personal level, then that helps them to feel a part of the organization. It helps them to feel valued and appreciated and more likely to stay. So in another presentation, I have a whole section that I talk about that. So maybe we could talk offline about that. Oh. Yes, sir.
So my question is more
Definitely. In fact, with accountable care organizations and a lot of those value-based purchasing models, there are increasingly arrangements where non-medical home care caregiving companies and providers are being brought in to work with skilled care providers in a holistic way to support that patient. And, you know, for example, when you think about the Medicare, the hospital recidivism that we've got problems with Medicare docking hospitals pay for CHF readmissions, for example. Those hospital systems, some of them are reaching out to home care companies who are spending lots of time in the home with those patients after they've been discharged to help ensure that they're taking their medications, that they're going to their follow-up doctor's appointments, and thus preventing the whole hospital readmission issue. And so those types of models are starting to proliferate, and I think they're going to continue. Was there a question over here? Yeah.
Like 5,000 people that you have to talk to all the time and whatever. We just switched to a company called Paylocity, and the supervisors can actually just send emojis to their supervisees, and we have seen a 70% increase in reduce in turnover just from these emojis. So, you know, it costs nothing. So there are, I agree with you, there are very, very simple ways to, you know, decrease your turnover and have people grow in the company and become supervisors and, you know, become executives and things like that.
Yeah.
So if anybody, it's called Paylocity if anyone is interested. But
I do think that you also mentioned kind of a career ladder. That's an important part of keeping people, giving them the opportunity to grow.
Upward
to grow
mobility.
Up.
Yeah.
Mm-hmm. Yep. For sure. Yeah, I think right behind you. Oh.
Yeah, hello. Did I catch your attention? Sorry, I just had a comment, which I'm Charles. We had a discussion last.
Oh,
yesterday.
Charles, you're in the very back.
Yeah. Forgive me. Just thinking aloud, you know, for most of us working in low and middle income countries, and you describe a wonderful scenario of the roles, the rewards, the responsibilities, the realities of a caregiver, which is fine in places or countries where, like most of us stay in Switzerland, in the United States, is good. But in low and middle income countries, the infrastructure, the resources for taking care of the aged is still yet to be optimally realized. And at the United Nations and the WHO, we are pushing for universal health coverage, whereby by 2030, nobody should suffer financial hardship because of lack of access to health, especially in low and middle income countries. So we have to think a bit further. If you ask the question, you have to live with the answer. If we are going to push for universal health coverage, which means the 11 years, the aged will be still there. Right now, they don't live long enough in most instances, but by that time, we have a huge population to take care of. And we have to think about developing the infrastructure. So I just want to share that with the audience, and I shared it with you, and I invited you to the United Nations in Geneva in December to share with us your thoughts. We have to think about it. It's an open challenge to all of us. Thank you.
Amen. Thank you, Charles.
One question on the financial side. My understanding is that some of the Medicare and Medicaid programs have started to actually include this as part of some of the Medicare waivers or Medicaid waivers that they'll do, where you can actually directly reimburse caregivers.
Yes.
I actually don't know how far along that is, how robust that is. Is that an area that you see a lot of growth in the next 5 years?
That's been happening in the Medicaid program for many years. There are certain rules, and you have to comply with all of the bureaucratic requirements. But family caregivers have been getting paid through Medicaid for a long time. It's not a living wage. It's not something that's going to allow them to sustain themselves. But from a policy standpoint, the reason that it's always been there in Medicaid is it's cost effective. It saves the government money, to pay a family caregiver this low wage while they're doing so much of the work, and it actually keeps the Medicaid recipient out of nursing homes, which is where the costs start to spike for the Medicaid population. Also on the Medicare side, just this year for 2019, Medicare Advantage is starting to recognize home care as a reimbursable expense, and I think that's going to be transformative in the industry from a paid, non-skilled caregiving standpoint.
Okay, guys, unfortunately,
you.
that's all the time we have for now, but please see Dr. Aaron for any other questions later today and during the cocktail hour. Thank you so much for that enlightening speech. Thank you very much.